that's why I do what I do every day. And that's why even though screening mammograms, are the mundane, they are the everyday, they are the bread and butter, they are incredibly important. And every single one of them is a chance to save a woman's life.
Session 9, Dr. Anjali Malik, how are you doing tonight?
Doing well. Thank you for having me.
I'm excited to chat with you and hang out with the 1,000 or so students that are here hanging out with us tonight and talk about breast imaging, breast radiology.
Yes, let's do it.
Let's talk about radiology as a whole. One of my favorite questions is, what are some of the biggest myths or misconceptions around radiology that pre-med students have?
That we sit in a dark room all day is obviously, or that we're all vampires. So so not a vampire. I do get some sunshine with sunscreen on. I see patients. I don't sit in a dark room all day. Obviously, as a breast imaging radiologist, I am unique within the field of radiology in that I'm seeing patients every single day. Sometimes I have my own patients, that are following up with me year after year. I do a lot of procedures, which is not unique to just breast imaging, but for me as a breast imaging radiologist. So there are dark room days. Sometimes it's the whole day. Sometimes it's snippets through the day, but it's certainly not all day, every day. I couldn't do that either. So I certainly understand why pre-meds who think of radiologists as just, sitting in a dark room and something they're not interested in. I totally get that. But luckily that's not what I do. So I think that would be the biggest one, honestly. That's the one I hear.
Yeah. Yeah, I think if you look at some of the fun, which are more comedic than true, like the algorithms of what specialty should you choose, and it's definitely like, I'm not a people person. I want to be by myself. Radiology gets that bad rap. Breast imaging and breast radiology, obviously, there's a lot of procedures potentially involved with it. What other, from your experience with radiology, what other fields of radiology have more of that hands-on patient aspect of it?
Well, I can answer it directly, but I can also answer it indirectly in that any field of medicine, and I'm sure you've heard this from the other physicians you've interviewed, you can make of it what you want. If you want to sit in a dark room all day and never talk to people, there is a way to achieve that, teleradiology or whatever. There's a way to achieve that. And, the world needs those people too, to just sit in and grind. And when it comes to procedures too, you can do it in almost every field of radiology because we really are, against common belief, very hands-on. So, of course, interventional radiology, which is almost not even considered part of diagnostic radiology anymore, although you will see a lot of hybrid careers, particularly out in the community and private practice. Body imaging, which is such a general and broad term, but, we biopsy everything, head to toe in radiology. I'm a breast imaging radiologist, but I do thyroid FNAs almost every single day. And because I'm willing to, stick a needle in the thyroid and stick a needle in the breast, I get requests for lymph nodes all over, or the, unknown masses that, if it's deemed safe. So again, if you are a radiologist and you are comfortable with procedures, there's a way to incorporate that into your practice.
How does someone go from going to medical school to wanting to do radiology and then figuring out that there's this whole, what I would consider a specialized field in radiology where you get to do a lot of procedures and hands-on stuff? Did you start with more of the, I want to be hands-on, and then you found radiology and breast imaging radiology, or did you start with radiology and find breast imaging radiology after that?
So neither. I'm being a very difficult interview.
No, I love it.
Yeah. So actually what happened, I thought I wanted to do medicine. I actually never wanted to work with my hands. I was terrified on the medicine rotation to even do like lumbar punctures and paracentesis and stuff, which now, give me the needle, I'll stick it in. But I thought I wanted to do medicine. My medicine rotation was eye-opening in the fact that instead of being all the zebras and all the fun that is morning report, it was, more of hypertension, diabetes, and things that I just didn't necessarily, it didn't pique my interest. Yeah. And my next rotation was surgery. And I happened to work with a general surgeon who pre-Katrina, so I went to Tulane, went through Hurricane Katrina. My third year was the year after, so 2006. And pre-Katrina, this surgeon had been in private practice, carving out kind of a breast surgery niche. And so he came back to Tulane, and even though he was one of our general surgery attendings, he was trying to rebuild that practice. And so in addition to lap choles, lap appies, all of that bread and butter of your general surgery rotation, I was actually doing a lot of fibroadenoma excisions. I was actually independently excising them as a med student. I don't think that the average med student has that experience. And then I was seeing all of his breast patients in clinic, helping do ultrasound core biopsies, helping do stereotactic biopsies. He was one of those surgeons that did a lot of that in his own clinic. And so I sort of approached it from that aspect. So in that month, I discovered that I'm A, pretty good at, and B, like to work with my hands. Never would have wanted to sit in a dark room and things like that. And so I went into radiology actually knowing that I liked breast imaging. But most of my colleagues, it's the other way around where, they like radiology and then they determine that they like breast imaging. For a lot of women, they have some sort of personal relationship to breast cancer or to some other reproductive cancer. And so a lot of women will go into radiology and breast imaging based on personal experiences or family experiences. Whereas I find a lot of the men who are in the field come upon it and realize it's something that they like to do.
Why did you not go into general surgery and become a breast surgeon?
And that's a great question. The breast surgeon with whom I worked said, okay, so, general surgery, breast surgery fellowship. And I was like, no, like, I don't want to do 5 years of general surgery. And what if 5 years down the line, I don't actually like breast surgery that much? Like, that's a huge commitment to make for something that, of course, taking out a fibroadenoma as a med student is cool, but like, was I really going to like mastectomies all day? And the answer for a lot of people is yes. I didn't necessarily think that was the case. I think I liked these short hits of procedures, right? The ultrasound core biopsies, these, even the small excisions, things like that. I'm a very goal-oriented person is what I realized. And so I like the start to finish. I like the reading the mammogram and calling it normal or abnormal, seeing a patient and finding their abnormality and making a plan for it. And it's not to say that surgeons don't do that. It's just to say that in breast imaging, it's a tighter package. And I liked the way that those procedures were. So, and again, the 5 years of general surgery didn't appeal to me. If you knew me during my 5 years of general radiology, you'd say that there were times where that was just as hard. I mean, radiology residency at UT Southwestern Parkland Memorial Hospital was not an easy breezy residency, which, on the other end of it is a great thing that I, have seen all of that. During it, though, it might as well have been general surgery.
Yeah. You talked about the bread and butter from a general surgery perspective. We've talked a lot about in these eShadowing sessions that in your specialty, you have to love the bread and butter or else you're going to be miserable. What's bread and butter for you? Screening
mammograms. So, I read, like, on any given day, I could read 90 screening mammograms. That's a heavy day. But you have to like reading screening mammograms and the minutia. I mean, it's a lot of, being very detail oriented, staying focused. And, those are the darkroom days. And also breast pain. So breast pain is the number one most common complaint that we have on our diagnostic days. And, being able to have a conversation where the patient feels like their symptoms are being acknowledged, but also being able to, sort of bring them down to, breast pain is very common. It's often hormonal or musculoskeletal. Being able to go through those and acknowledge the patient, but also get them moving forward. I do that no less than 5 times per day. And it's a conversation you need to be comfortable having a lot.
Yeah. Talk about those diagnostic days. It's interesting. I think again, going back to when you say radiologist, what students imagine in their head is sitting in a room, reading, maybe doing some fine needle aspiration. But it sounds like you are actually going into a room, examining patients, like a quote unquote normal diagnostic internal medicine doc or family practice doc. What do those days look like for you? How are you interacting with patients?
Yeah. So like this morning I was on diagnostics, as you know, or those are the days when we are seeing patients who either have a symptom, their doctor feels something, or, you know, we called them back from their screening mammogram, or there's someone who's very high risk, personal history of cancer, strong family history, known genetic mutation, et cetera. And so they, instead of just coming for a screening mammogram where they come in and leave and get a letter in the mail, they come in and get their results same day. And oftentimes, particularly for those who are called back or have a symptom, it's so that we can do any and all mammographic or sonographic imaging same day. So not interventions and not MRI, but at least mammographic and sonographic workup. So if a woman feels a lump, the technologist is doing her mammogram, I'm taking a look and then going and targeting an ultrasound to that area or any other area I might see. So pre-pandemic, I was typically doing 14 of those per half day. In the middle of the pandemic, obviously with social distancing, sanitizing, et cetera, it's a little bit hard to keep up those volumes. So, but yeah, so I saw 12 patients this morning. I think of those, like 8 of them needed ultrasound, and I talked to every single one. And sometimes those conversations are, your mammogram looks fine, you're good to go, see you next year. And sometimes those conversations are a 20-minute, 30-minute, like, I see something, you need a biopsy. This is what a biopsy is. This is what it means. Or like, I very often see women who, in my professional opinion, haven't gotten the counseling that they need when it comes to their breast cancer risk, their need for genetic testing, or like what their actual genetic mutation means for them. That's something that I specialize in. I'm on the medical advisory committee for Bright Pink, which is a nonprofit that aims to educate and empower young women on their breast and ovarian cancer risk. So I'm very familiar with genetic mutations, particularly as they pertain to, breast cancer risk. And I so often see young women who either have no idea that they need to get genetic testing, or again, don't know, I have this mutation and these are the things that I need to be doing. So my diagnostic days can be easy breezy, or they can be, 12 to 14 patients of 30 minutes each. And just like a regular clinic day for, I guess, what internal medicine would be. And then a biopsy day can be, ultrasound biopsy, mammogram biopsy, MRI biopsy, ultrasound biopsy. So, ping, 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 I'm going from room to room doing biopsies. And so, yeah, I mean, I saw patients all day today.
Nice. I'm going to mute you when I talk, although it doesn't look like it's muting when I do it, but I don't hear an echo anymore. So there was a bunch of echo coming through, but I don't hear it right now. A good question came through. It's a student who's interested in working with the LGBT community. How, as a breast imaging radiologist, trans patients, how are you seeing those patients? Are there special clinics potentially where they go to where there's a little bit more care given to them, or more sensitive, where they're more comfortable? How is that taken care of in your clinic?
That's a great question. So we actually don't treat anybody, male, female, trans, cisgender, transgender, differently. So if you come to our clinic with an issue, we work it up, period. So cisgender men are going to be taken through a different entrance and, sort of walked around away from the women, just to make everyone feel comfortable. Although in the setting of COVID, we really don't let any patients near each other. We're so distant, so that's really not even an issue right now. And when it comes to transgender, admittedly, in my decade of
just to interrupt real quick, when you say cisgender men, a lot of people are like, "Wait a minute, you're a breast imaging radiologist," but people don't realize men get breast cancer.
Men get breast cancer, or men can have lump or pain or et cetera. They can have genetic mutations. they can be BRCA carriers, Lynch carriers, things like that. So yeah, so we see men not as frequently. I would say in a week we get 1 or 2 across 7 offices, but we do see them. And then when it comes to transgender, again, in a decade of practice, I've only personally interacted with 1 or 2. And, I can't speak to whether we were like, would you feel comfortable coming back? Or, I don't know how that transpired. I think it's something that everyone is more aware of as time passes. But I will say what we did not do was treat them any differently they didn't get put in a corner, and their imaging is no different. I mean, if you have breasts, which everyone does, even men, you get a mammogram. So if you're above the age of 30 and you have breasts, you get a mammogram. If you're below the age of 30, you get an ultrasound, and that's just the way it is in my book and in the breast imaging book. The other thing is, so trans women and men both still need mammograms because it's the exposure to estrogen that determines whether you're going to get breast cancer. If you've had any exposure, unless you had a prepubescent transition and didn't have that, exposure to estrogen, you pretty much need to have mammograms.
Yeah. I'm excited to jump into some of the slides that you have, some imaging that you have, and then we'll do some Q&A with the students after.
Sure. So I'm hitting this computer that says share screen. So just to preface, basically, again, the idea is that I just look at black and white images, and I'm just looking at these like really fine, combing through images with my magnifying glass kind of thing. And some of that is true, but we use a lot of different modalities in breast imaging. So we've got X-ray via mammograms, we've got ultrasound. I'm doing my own ultrasound. I'm using both of those to guide biopsies. And I'm going to show some images now, but we don't even just have like the standard X-ray. We have tomosynthesis, we use MRI, we have nuclear imaging. So the goal is really to just say so much that what I do is cool.
You have lots of toys.
Yeah, exactly. So let me see. So a couple of things that I like to preface with also why I do what I do. The point of breast cancer screening and screening mammograms is early detection, and any screening, whatever it is, colonoscopies, pap smears, the goal is early detection of a disease that when caught early can be cured. So these numbers here hopefully show that, if we're catching cancers early, they have a 100% chance of survival, versus if we're catching them late, they have as low as a 20% chance of survival. And so that's why I do what I do every day. And that's why even though screening mammograms, are the mundane, they are the everyday, they are the bread and butter, they are incredibly important. And every single one of them is a chance to save a woman's life. So that is why I do what I do. And just to give you some numbers, even if you're just premeds who are not just premeds, but even if you're premeds who plan on going in something else, you will have a mom, a wife, a daughter, a sister, someone who's going to be affected by breast cancer screening. And so I think these statistics are really helpful to empower the women in your life. So if 1,000 women get a screening mammogram, approximately 125 of them will be called back for additional imaging. And of that, approximately 20 will be recommended for a biopsy. So those other 105 are going to be what gets called in the news as false positives, but they're not really, they're false positives in the epidemiologic sense, but they were real at the time of callback. And of those 20 women, only 5 will have cancer, which if you're one of those 5, it's not, a small number, but so much to say that, of that 125 that got called back, only 5 have cancer. And so the chances for getting called back are much higher than the chances of having cancer. But as the first slide showed, if we do detect it early, you have, pretty much 100% chance of survival. So this is a mammogram where, of course, you're seeing black and white. To me, I'm seeing tissue and fat. So the white on the mammogram is tissue, and the black on the mammogram is fat. And one of the problems is it's not just tissue that shows up as white, but also cancer that shows up as white. So if you were to look at this mammogram, you basically wouldn't see anything abnormal. And in the old days of 2D mammogram, we probably would have just called this a normal mammogram with dense breast tissue. Dense referring to a higher proportion of tissue than fat inside the breast. But luckily, this happened in the day and age of tomosynthesis. So tomosynthesis, I'll show you in a few slides. It's basically like a movie of the breast. So I'm going to play. Hopefully this works. Oh, of course it's not working because it's a screen share. But basically, if I were to go through these images, and I'll show you what it means to go through these images, it's like a flip book, and it goes through the breast layer by layer instead of just a picture. So it's like going through a flip book rather than just looking at the book when it's closed.
Is it almost like thin slices, like a CT thin slice?
Yeah, it's poor man's CT or poor woman's CT.
Poor person CT.
So yeah, exactly. So tomosynthesis, that's literally what CT is, except that's computed, tomography. Mm-hmm. And this is not as high radiation dose of that. So what we end up seeing is a mass that was actually here that was really well depicted on those tomosynthesis views, which I'm sorry we couldn't see. I can play them on my screen. I think it just probably doesn't work with screen share. But this cancer would have, been missed and wouldn't have been detected until it was palpable. And here is an ultrasound of that mass, which, just to go over some quick breast imaging findings. So this is, an irregular hypoechoic mass. And I'm sure if I had some color images, it would be really hypervascular, and I would be able to, give it a BI-RADS 4 or 5, meaning it was suspicious, and recommend it for biopsy. So I referenced dense breast. Basically what that means is having more tissue than fat. And as that mammogram that we saw hopefully depicted, it's really difficult to detect breast cancer in women with dense breast parenchyma. So there have been a lot of movements over the last 10 to 15 years in educating women on what it means to have dense breast parenchyma and informing them when they get their screening mammogram so that they can talk to their doctor about what their imaging options are. Tomosynthesis has been a huge advance in the imaging of dense breast tissue, as well as ultrasound and MRI. So
how much does, let me ask a couple of questions that have come up around the same thing with breast implants. How does that affect breast imaging radiology?
So sure. So we can definitely talk about that. If you want to just look at this quick schematic, A, because it's cool, and B, because, so I hope you can see the different images that are playing out there in the tomosynthesis. Yep. And see how basically through the different angles we would be able to detect breast cancer better by doing those tomosynthesis. So for breast implants, women who have breast implants can still get mammograms. They, we do views with the implant in view and without the implant in view, called displaced views. It can obscure some of the posterior tissue, particularly if they're placed in front of the pectoralis musculature. Those that are placed behind the pectoralis musculature, we still get much better views. It can obscure some of the lower inframammary tissue or some of the higher axillary tail tissue. And then we do some special imaging for silicone gel implants. It's not as relevant with the newer generations of silicone gel implants, but previously they used to have intracapsular and extracapsular rupture. Mm-hmm. And so we had to evaluate the integrity of those implants with ultrasound or MRI. You can have like silicone granulomas that form with some of the older ones when that silicone extravasates and leaks out of the implant. So you can have like hard lymph nodes that develop from it or other hard masses. But overall, implants are very common and we see them in our patients. So sometimes they can affect our ability to perform a biopsy, like if a mass is right directly over the implant, but it's otherwise not really a huge problem for us.
Yeah. Can you click the hide button there on the bottom there?
Yeah. Sorry about that. So this is another example, rather than the schematic. This is just showing you here on the screen left. This is what a normal 2D mammogram would be like. I mean, this is what each of those tomosynthesis slices would look like. So wow. You're basically looking at the breast at each level. And so instead of having this slice overlap with this slice, you get to see them separately, which, in these slices doesn't necessarily mean anything, but in some slices could mean that you're revealing a cancer that would otherwise be obscured.
How much extra radiation is with this compared to a normal mammogram?
It's a minimal increase per screening 2D mammogram. It's still within FDA limits. And then more importantly, if this saves a woman a callback by revealing, or in the same way that it reveals things, it also clears up some of the callbacks that women used to get. And so it can, in many cases, save additional imaging of a callback or like follow-up imaging if we're unable to clear it and things like that. So overall, the increased radiation dose is felt to be clinically beneficial.
Good.
So,
and then talk about because we're getting a lot of questions about kind of what's the diagnostic steps after this. So you see something suspicious, you call the patient back. Like what are the next things that happen to determine, is this something bad versus something benign?
Yeah, so kind of like what this was showing. So we would do spot views. Spot is where you focus the mammogram just on an area of concern, and then ultrasound, to work up anything that we see on a mammogram that we want to see, if it's a solid or cystic mass or lymph nodes, look for skin thickening. Magnification views is how we work up calcifications. And then, of course, we have other tools in our belt, which I can move on to next. So, 2D ultrasound is what we're most familiar with. That's what these views were. 2D, it's just the handheld probe, those sound waves going down into the breast, coming back to the probe and showing us what masses are. 3D ultrasound is it's doing the whole breast at once. And so this is a 2D mammogram, so it doesn't have those 3D tomographic views. This was done it was done in my fellowship before tomosynthesis was really widely used. And so if you looked at this mammogram, I know none of you look at these every day like I do, but it really just looks like dense breast tissue. And in the days pre-tomosynthesis and pre-3D ultrasound, et cetera, pretty much this woman would have just gotten, you have dense breast tissue. We don't see anything acute. You're good to go. But on 3D ultrasound, where an entire ultrasound of the breast was being performed by an automated machine, this irregular hypoechoic, hypo meaning low, echoic meaning low echoes. So when something is solid, the sound waves aren't able to penetrate through it, and therefore they're not able to also then bounce back to the machine. Versus like when something is liquid, the sound waves travel through it, down, and through it back, and it shows up black because it has no echoes inside it.
Oh.
And so this is an irregular solid mass that did go on to be a breast cancer. In the same way, mammograms and ultrasounds take pictures of the breast, and they're obviously very useful for diagnostic imaging, but they're just kind of like taking a picture in time, and they don't really look at what's going on at the cellular level. And so for that, we have functional imaging, meaning tools that are able to tell us what's going on at the physiologic or cellular level. So all of those require the injection of something that then is taken up in cells using all that fun, sodium, potassium channels and ATP and all those things that, you don't really like to learn about, but you are. All of those things do play a part in how we do radiology. So both for physiologic imaging, like MRI, which uses intravenous contrast, like contrast enhanced mammography, which also uses contrast, and like the molecular imaging, which uses tagged radio tracers. So, you're using all of those fun cell biology and physiology things that you're learning right now. They are what help me do my job in detection and diagnosis of breast cancer. So this is one using a contrast enhanced mammography. So this is those 2D views. And this little triangle here indicates that a patient was feeling something. This was actually, this way that she was feeling went on to be a breast cancer. And you see that here. So these were images from an outside facility. The patient came to me for contrast enhanced mammo or mammography. And that's where using mammography, we give the patient contrast, and then we take these really low energy films just to be able to see if there's any enhancement. And so if you'll remember, this is where her marker was, here. Yep. And that took up some contrast. And it's such a tiny lesion, but we already knew it was cancer. So of course we believe it. So there's a matching lesion. I mean, these almost look like mirror images, but this is the opposite breast and a little ditzel enhancing just like that. So
is that a very technical term, a ditzel?
Ditzel is super technical. Yeah, especially when they're this tiny, they're definitely a ditzel. And so, so we have this little thing that's enhancing exactly the same. And we said, okay, we might not, have been inclined for something that small, but it looks exactly like her biopsy-proven cancer. And the same goes for this side, even smaller. This is the diagnosis. Wow. This is the opposite side. Yep. And so, in that woman with the dense breast tissue that she had, we never would have found that. I mean, we never would have found that. I mean, I would like to say I was that good, but it's just in reality, we just know that we're not. And
with the advent of machine learning from Google and other companies getting on board with using technology to help radiologists evaluate these screens, do you think a computer could have found that and potentially?
No, I don't. No. I think tomosynthesis might have been able to find it.
Yeah.
But again, I'm showing, these cool cases that I have are pre-tomosynthesis.
Yeah.
In the world of tomosynthesis, we're so much better at finding cancer. And I also work in private practice now where our patients are really heavily screened. And so I am lucky in that I am not finding all these crazy cases anymore, right? Because my patients are getting screened, they're getting tomosynthesis, we're finding lesions when they're super small. Yeah. We're not getting these gotcha cases, like we used to, where, we're looking at a sheet of white paper practically and there's cancer hiding behind it.
Yeah.
Of course, that's not to say that doesn't still happen. It's just in my anecdotal experience, it's less common. But again, I have very heavily screened patients.
Yeah.
In these academic centers, you're going to be seeing a lot more of the, people walking off the street having never had a mammogram and having a fungating mass. I mean, that quite frankly happened very frequently, both in my fellowship, my residency, and my first private practice, which was in a more rural area. It's not to say I don't see really cool things in private practice or rare things. They've diagnosed all sorts of different kinds of lymphomas and leukemias and tuberculosis and things just on mammograms, lymph nodes, things like that, right? Because this is these are the axillary nodes that we're seeing. Mm-hmm. So I diagnose a lot of cool things, or cool, in the medical sense. But yeah, just not all these gotcha cases that we necessarily were getting before. So
yeah. And just to clarify, because a lot of students are still asking, once you see this from a radiology perspective, you're going in with a needle and actually biopsying, so you can actually have a pathologist look at the cells, correct?
Exactly. So gone are the days of you have a mass, it has to be cut out. It's you have a mass and it needs to be biopsied if it's suspicious enough to warrant biopsy. And the modality under which it's best seen is how it's biopsied. So, for example, this, at that time actually was a really complicated workup because we didn't have the ability to biopsy with CESM, and we couldn't find it under mammogram and ultrasound. So the patient ended up getting an MRI, which did confirm this lesion, and then we biopsied it under MRI. It didn't confirm it was a cancer. But for example, with these other cases, this was biopsied under ultrasound because that's how we saw it. And we, were able to prove that it was cancer. Had the lesion here been something that we could have seen, for example, these days on a tomosynthesis, we could have biopsied it using tomosynthesis. We have that ability now. And the next case that I'm going to show you, and if we find something on MRI and not anywhere else, we can biopsy it under MRI. And then this is the other modality that I was going to show you. So BSGI is breast-specific gamma imaging. So it's nuclear medicine. So you think nuclear medicine like PET CT or bone scan. We have these tagged radio tracers. And so breast-specific gamma imaging is a tagged system. Maybe it's the same concept where it's taken up in areas of increased activity, same as MRI, same as contrast-enhanced mammography. Because again, we think cancer cells rapidly dividing, lots of that sodium, potassium channel, lots of glucose. A lot of these types of things are FDG tagged. That's how PET CT works, is with a tagged glucose. And so, so we're looking at areas of increased activity. So this is, again, a 2D mammogram, which if you've gotten one lesson, it's that we don't like 2D mammograms anymore. And so 2D mammogram, sheet of white paper, basically, because it's a lot of dense breast tissue. And, unfortunately, we just used to miss a lot of cancers in those. And so this looks like a totally normal mammogram. This woman, of course, in retrospect, it's easy for me to find the lesion, but, this is a woman with high risk, which meant she either had strong family history of premenopausal breast cancer, unknown, genetic mutation, et cetera. And so she got her screening mammogram and it was called negative. But luckily, she was getting high risk screening with something else in addition to mammography. And on BSGI, you see the bright or the dark, whatever spot, as it were, in that right breast. Of course, totally different from the other side where you've got homogeneous take-up. And so, an ultrasound was directed to that area. The lesion was found, and it was a cancer. You can also do biopsy with BSGI if you have that equipment. So,
wow.
So if I can now not share my screen. But yeah, so that's all I have for slides for now.
So let me ask, if you want to come on and ask some questions, raise your hand or click the little speak button, and I'll bring some of you on to ask some questions. Just in general, you mentioned it in passing, but I think a lot of students missed it. The training path to become a breast imaging radiologist. What does that timeline look like?
So it's so your normal 4 years or 7 years or 6 years of pre-med and med school, however you're doing that. And then it's 1+4. I went to one of the last 5-year programs where my intern year was integrated into my radiology program. That was at the at the University of Texas Southwestern. Not a lot of, I don't even think any of those exist, or maybe just 1 or 2 around the country now. It was really cool for me because my intern year was tailored for radiology. We did a ton of emergency medicine, which is very important for particularly a training radiologist, maybe not in my life now, but we did urology. We actually do quite a bit of GU in radiology, whether it's looking for renal stones, hydronephrosis, things like that. So a lot of GU. We did pulmonary, ortho, of course. What else did we do? I can't think of anything else, but it was a really cool year. But otherwise, your intern year can be whatever you want. If you want to do the hardest, most intense prelim medicine or surgery, or if you want to do one of those transitional years that's on the golf course, it doesn't exist anymore, then that's fine. And then you have 4 years of radiology. And then most people these days go on to do a fellowship. The main ones being, of course, breast imaging, like what I did, which is 1 year, not ACGME accredited. So the only ACGME accredited fellowships are pediatrics, neuroradiology, and interventional radiology. So those are the ones where you are taking a test or a CAQ, and the ACGME is actually regulating those fellowships. Yeah. There are also like MRI fellowships, body fellowships, women's imaging fellowships, things like that. And now there are like informatics fellowships and all sorts of different options. So, and also these days with the increasing utilization of interventional radiology and minimally invasive technologies, whether it's endovascular, whether it's, cancer therapy, renal therapy, as we continue to have diabetics and hypertensives who require dialysis. It's just such a booming field. And so there are direct to IR paths, there are DRIR, diagnostic radiology, interventional radiology residencies, and I couldn't even begin to speak to those because they didn't really even exist when I was in training. So that's how quickly the landscape has changed.
Very interesting. Thanks for that. All right, Shane, we'll get a little feedback again. Shane, go ahead and ask your question there.
Hi, yeah. So I had a question. You mentioned you kind of have like biopsy days and like diagnostic days. Like, how into your schedule do those fit in? Are they consistent, like every week? Like you have 3-2? Are you just kind of random? Like, I'm interested to hear a little bit more about your schedule with that.
Sure. I'm sure that there are places where they're regimented with their schedules, but in the real world, we have 7 offices and 25 radiologists to cover them. And it just depends on who's off what day and what office needs to do what day. And like today, I was only supposed to read see diagnostics in the morning and read MRIs in the afternoon, but we have a lot of patients who need biopsies. We're still catching up from the pandemic. And so I added on some biopsies and I added on some screens and so in the real world, no. And it's funny because my other friends who are in medicine actually will be like, what days are you in your Virginia office? And I'm like, whenever they schedule me there, so it's not quite like a lot of my internal medicine friends have like clinic this day and this, that, or my surgery friends like operating room 2 times a week and clinic on Fridays. And that's just not radiology. We're the doctor's doctor and the patient's doctor. And so we are here to serve.
The best quote I love is a Mike Tyson quote about everyone has a plan. Everyone has a plan. Punched in the face.
Right. Yeah. Exactly. Yeah. And I don't want to say that's every day because that sounds bad, but that's just every day. I mean, like, best laid plans. Like I literally just do what is needed, which is what private practice calls for.
Yeah. And actually, I have a quick follow-up as well. How does that kind of play into your work-life balance?
So I leave the office and I leave the office. And I'm of the mindset, not during training, but in real life. What happens when you stay in the hospital late is you stay in the hospital late. Like, you don't get a medal, you don't get brownie points, you don't get whatever. So I finish my work and I leave. Do I take home some of the stress? Do I take home some of the, I saw a 27-year-old that had breast cancer? Yes. But I am luckily not one of the, my friends are always bemoaning charting after their kids go to sleep and I don't even know what that means. Like, I've never had to do that, thankfully. I have plenty of dictations to do every day. I have so much documenting. I do call patients after hours with biopsy results sometimes. I'm literally like in my car, headphones in, giving biopsy results. But I would say radiologists have good work-life balance outside of work. I would say during work, depending on where you are. It's not that there's not work-life balance. It's just, it just depends on what kind of practice you're in. And if you're in one that's meant to take care of, a high volume of patients, then just show up and work is kind of the sentiment sometimes.
Thank you.
Thanks, Shane. Mohammed.
Thank you so much for the opportunity. I don't know why my camera is not working. Oh, here we go. Mm-hmm. Hey, I'm very curious as to, since you do work within radiology, you kind of see a lot of medical physicists that work with you. Now, in terms of artificial intelligence, now my thesis was centered around artificial intelligence kind of promoting or even aiding in terms of creating personalized treatment plans. Now, where do you see artificial intelligence, and do you see it as a potential aid in the future?
Yeah. So, the question is always, is AI going to replace me? That answer is no. Will it answer? That answer is yes. So as the person who, again, whether it's as simple as breast pain and it turns into a 20-minute conversation, a computer is never going to be able to do that. When I try to simplify it and, take it down to a level that I hope that my patients will understand, it sometimes requires a lot of counseling. And I don't think a computer is ever going to do that. And that's the thing with breast imaging. People think I just sit in the darkroom and read mammograms, and that is not what I do. So much of what I do, we call it mammochiatry, right? So we're part mammographer and part psychiatrist. We just are. Our patients are very
anxious,
high anxiety, and particularly if you're in an urban area, it's just another level. And so I don't think that aspect of my practice will ever be replaced by AI. When it comes to the interpretation of films, there are a lot of different programs. There are a lot of different studies. Google tried to say that their software could win, whatever. So far, that none of them has really proven to do that. So first of all, we've had computer-aided detection for like a decade, and I'm unimpressed. It put lights up on all sorts of things that it's like a med student would know that that's like normal tissue or a benign calcification or whatever. So, I remain to like, I'm holding out on actually being impressed. I know that the future is there. I just don't think that we are there. But I think if a computer could, burn through a stack of films and then me go through them, and we don't have stacks of films anymore, they're on the computer, but in theory, a stack of films, and me, do the second look and say, I agree next. It's like having a scribe and a second read and all of those things at once. And if that frees up time for me to be able to spend more time with patients or read more screening mammograms or whatever, that's an improvement on the healthcare system 100%, but it's not replacing.
That's kind of where I was kind of getting to. With this potential that we can see with computers, this wouldn't be a big problem within the United States or Canada, or even any really highly developed and densely populated.
To radiologists absolutely globally, there's a shortage of the amount of healthcare providers to the amount of patients. For someone like me who has a public health background, I want to be able to serve as many patients as possible. That's the goal of any screening, whether it's breast cancer or colon, whatever, is, again, getting something that's quick, easy, cheap, out to the population, that can be performed and on the population. And if AI can make that more accessible to people, then by all means, that was kind of my center with my thesis. It was mainly the idea of one of the struggles I found within my medical physics master's is the lack of the ability of creating a personalized plan for individuals experiencing specific malignancies. And then having this opportunity to make it much more personalized rather than just a generic version. I found it very helpful, especially for countries that aren't able to provide the same level of healthcare compared to the United States, Canada, and even the UK, Australia, those places. Yeah.
I agree with everything you said. Thank you so much for the opportunity. You guys do great work.
Thanks, Mohammed. Oh, very cool. Dr. Malik, I'm going to call it quits here. I know you have another engagement after this. Thank you so much for sharing your wisdom, sharing your specialty, sharing those slides, and hopefully getting some more people interested in breast radiology.
Absolutely. Thank you for doing this. I know I got feedback just from your post and my repost that, you've got obviously a ton of viewers, ton of followers, and hopefully people are benefiting from this. So thank you so much.
Yep. Have a great night. Thank you everyone for coming.